Hello and welcome to WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio Menard. More than 70% of individuals with cancer will survive and go on to live their remaining lifespan cancer-free. Even for those with advanced cancer, today's treatments lead to longer life. The downside is that many will experience side effects from cancer treatment that prevent them from completing daily activities, resuming work, or participating in social and family activities. Many will suffer long-term effects that are often disabling. The WVU Cancer Institute Survivorship Program is hoping to change that by addressing the physical, psychological, emotional, and support needs of cancer patients during and after treatment. So how do they accomplish all of that? We'll find out as we're talking with Dr. Nicole Stout of the WVU Cancer Institute Cancer Survivorship Program. Welcome, Dr. Stout, to Tuesday Talks.
Thanks, Mary. I'm happy to be here.
It's good to have you here. If you have any cancer survivorship questions, just submit them in the comments section below and we'll try to answer them live. So, Dr. Stout, let's start at the beginning here. What exactly is a cancer survivorship program?
Yeah, I think we have to step back and say, what is cancer survivorship? What does that mean? And the concept of survivorship has been around for decades. We learned back in the late 1990s and early 2000s, we were doing a phenomenal job of treating cancer, the disease. We weren't doing such a great job of treating and supporting the human being going through cancer treatments. You know, cancer happens in someone's life, but life also continues. They may have to keep working. They have children going to school. You know, they have to get through their day. And cancer treatments and its side effect have a negative impact on those abilities to function. So how do we help to better support patients as they go through treatment? So that was the concept of survivorship. And over the last decade, we in the oncology world, have tried to develop systematic approaches to better study the problems that patients have, meet the needs of those patients, but we've struggled. And so recently, we've had a national accrediting body that has said, we need to do a better job and we need a structured approach to programming, developing infrastructure and developing programs that can help to meet the needs of these survivors. And so since 2020, we've had accreditation standards for our cancer center that say you need to have a program, not just some good ideas, not just some one-off types of supportive interventions, but really a program. And so that's how we started to develop the survivorship program at WVU Cancer Institute.
Okay, and this is a relatively new program at the Cancer Institute.
It is. We've been doing work in survivorship to support needs through things like nutrition and rehabilitation and spiritual counseling. We've been doing those for years. But
Sure.
What is different now is that we have brought this together to systematically approach identifying when patients experience problems and to walk alongside them and help to support them during treatment and beyond when they have these issues. We know that those supportive interventions like exercise and nutrition can help to mitigate some of the side effects. So we've developed a systematic way to identify patients, provide them with those services when they need them. That's really the goal of the program, getting the right patient to the right provider at the right time to meet their needs.
Yeah, I know you don't want to just send them on their way once their treatment is over. And when you think about somebody going through cancer treatment, I mean, it's a very stressful time. They're not feeling well. How does the concept of survivorship and support services, how does that fit into cancer treatment, during and afterward?
Right. And I appreciate that you recognize that it's during treatment, but it's also long after.
Yeah.
So the other thing, it's not good enough for us to just let people go along their way. It's also not good enough for us to do what I call brochure therapy. We can't just give people a handout and say, here are some tips for exercise, here are some tips for nutrition. That's not good enough because people interpret that in different ways, and there is this fear. I'm going through treatment for cancer, I have pain, I have fatigue. Should I push myself or should I not? Should I extend into doing these activities or should I not? Should I take this on? I have these fears. Is that well-founded? Am I being crazy? Those are things that we need to step back and validate in people. These are very real things that happen related to cancer treatments, and there are very real solutions that we can offer to help to mitigate and reduce those issues and help them to better thrive during treatment. So what we try to do is we try to do an assessment of individuals' needs. We use a scale of distress, and we ask them, how much distress are you having? But not only that, we ask them to tell us a story about where the problem points are in their life. Is it family issues? Is it financial issues? Is it physical problems? Is it the psychological? Are you not sleeping well? So what are the problems that you're experiencing? And when we understand those, we can then help to direct the patient to the right place at the right time. And that's really what this program is all about.
Well, I know that, when you're going through cancer treatment and, there are side effects to medications and the treatment. And I think a lot of us, may think that, once your treatment's done, those side effects are going to go away. But that's not always the case, is it?
Yeah, and different people experience those side effects to varying degrees. Some people have very severe reactions and have persistent side effects. We do, for the most part, see that when treatment is completed and we go through chemotherapy and we expect to see side effects, we fully anticipate that people will be fatigued, their blood counts will change, they will have, some people will have swelling, they will have numbness and tingling in their fingers. We expect those things. We also expect that when treatment is done, that they will dissipate. But what we have learned is they don't go away completely in everyone, and that many of them can persist and cause longer-term disability. We see in cancer survivors who are beyond the end of treatment, many years, we still see deficits with their balance and their walking. They have a higher risk of falls. We see heart problems that can occur years after they've completed treatment. So it isn't good enough. This is an important point. It is not good enough for us to say, you've survived your cancer. You should be happy to be alive and go and live your life. It is not good enough because there's so much more that those individuals will continue to experience, and there's a strong evidence base in the research that introducing supportive care interventions like rehabilitation, psychological counseling, social work, nutrition, those things can help these individuals through treatment and beyond to mitigate the level of disability. So we can prevent long-term disability and prevent some of these long-term consequences by introducing these support services early.
And I imagine a lot of cancer patients feel after treatment kind of isolated, in isolation, like, surely I'm the only one that feels this way. Why don't I feel better? Why do I still have the tingling? Or, why am I so tired? I imagine that's part of the program as well, to reassure them that this is normal and you are not alone.
Yes. I think validating that even though treatment's done, you still may have these issues. And that doesn't mean that it is a consequence of you psychologically not being able to handle the diagnosis. These are real physical, real emotional, real consequences of treatment. There was a report by the Institute of Medicine in 2004, and it was called Lost in Transition, because that's how patients felt. And that report said, hey, we're doing a great job treating cancer. We're not doing a good job managing the human being. And when people finish cancer treatment, they feel like they fall off a cliff. They're seeing their doctors in the Cancer Institute very regularly. Somebody's keeping an eye on them at all times. They're coming in for a lot of appointments. And then all of a sudden, they're done. And we're supposed to just walk away. That is very troubling and distressing to patients. They feel like they're lost in that transition from completing treatment, moving into returning to their life. That's where supportive services from a survivorship program can help people make that transition. Give them license to say, you know what, exercise is actually good. Rest is not best. Getting up and moving can help you recover. Doing strengthening program, lifting weights, that is actually good. these are the suggested dietary tips that we can give you to help you feel better. It is normal to have fear. It is normal to have anxiety and lose confidence in yourself and your abilities. Here's how we can help you by offering these supportive programs. So you're right, people do feel lost and a little bit, sometimes even I think a little frustrated that they feel like, well, my doctor's done with me. And now they transition back to their primary care provider who may or may not understand the issues. And so this is why our program is so important, not just to help folks in our Cancer Institute through the diagnosis and the disease treatment, but really help to hand them off back into primary care and build capacity in the state around knowledge in our workforce to help these individuals in their communities where they're living so they don't have to come back to the mothership and to the Cancer Institute for repeated follow-up care. How do we build capacity in the communities? That's what we're taking on as well.
Well, we do have so many, it's a big rugged state, and
Yes,
people,
yes.
Our patients travel. A lot of them travel hours for treatment, and once that's over with, how do you help these patients when they're done with treatment find these services in their own communities? This kind of support.
Yes, well, luckily we have a really wonderful contingency of social workers at our Cancer Institute, and they do a wonderful job of helping patients connect to local community resources. One of the challenges we face is in our primary care settings. Our primary care physicians are wonderful around the state. They're busy, and they and their staff are sometimes overtaxed with patient caseload. And so focusing on cancer survivorship as a unique condition really isn't on their radar, and we hope to be able to build that recognition. We have new guidelines that suggest follow-up long-term care for individuals who've gone through cancer treatments. The guidelines suggest there are certain domains that primary care should be monitoring. But in general, and this isn't just in West Virginia, in general across the United States, we haven't done a good job of elevating the knowledge in that primary care workforce. So we do want to focus on that here. We are a big state. Not only are we large and rugged in the terrain, geographically speaking, we are rural, obviously.
Yep.
But rurality isn't just I live far away and I have a treacherous drive to get there. There are also challenges that we experience with telemedicine and telerehabilitation, right? We kind of give a hand wave to, well, telemedicine, we'll just do a telemedicine visit. Do you know how many patients I see that don't have a computer at home? Don't have internet access at home. So to think that we're going to be able to just use one strategy, right, or one tactic, we need a more strategic approach. We've got to think about the multiple ways to help these individuals to connect to resources in their communities, identify the resources, get them engaged and in touch, have that primary care support network there. But really at the end of the day, and we can give them all the materials and brochures and information and websites, but at the end of the day, patients have told us having a person that I can contact that knows me, that knows my care plan, that knows what's next for me or who to follow up with, that was one of the biggest deficits that patients reported when we just completed a statewide needs assessment study, was who's my person after I'm done with treatment? Who do I follow up? Who knows what I need? It's a big gap that we're working towards filling.
So now you're trying to go beyond the brochure.
Right? Brochure therapy doesn't work.
No.
I say that, and for some individuals, they don't learn that way, right? We know some people like to have
That's
a video.
true.
Some people like to read. Others don't. Some people like to hear a speaker. Some people like to sit in a support group and talk about it. And so we have to think about the multiple ways that our patients engage and learn. We also have to think about the multiple ways that our primary care professionals engage and learn so that we can bring together and create this community-based cancer survivorship approach that we desperately need, not just here in West Virginia, not just in rural America, but in general across the country.
So if you say you just finished up treatment at the WVU Cancer Institute, do you have to sign up for the survivorship program, or is this just automatically part of your treatment plan now?
Yeah, that's a great question, and I think it's important to realize first, this is a new program. As I said, we kicked off in 2020, and really we've been about developing infrastructure. And so our program seeks to identify patients during treatment who have needs, connect them to the services that they need at the right time. Now, what we don't have is a clinic. We don't have a clinic where people say, okay, I'm going to sign up and come to the Survivorship clinic for an appointment with a Survivorship doctor. We don't have that, and I don't know if it's pragmatic to think that we ever would, because cancer is so diverse. The needs of someone who has had lung cancer treatment are very different than someone who has had breast cancer treatment. And so to think that we could meet all of those in one place, it will be a challenge.
It's not a one-size-fits-all.
It is not at all. So really what we have done is developed infrastructure. We've created some really great, I would call it infrastructure pathways that have helped to connect the patients to the specialists. A great example, we have an occupational therapist who is a specialist in cognitive therapy. And so we know that chemo brain is very common among our patients.
Yeah, tell us what chemo brain
Chemo
is.
brain, good, right? It's just like what it sounds. When you start to go through chemotherapy, patients will say, yeah, I just feel foggy. I feel like I can't think straight. I can't read and follow a paragraph. I get numbers confused. And we used to kind of, oh, chemo brain, you're stressed, you have anxiety, you're a little bit anxious. But what we've learned is there are actual changes in neurological function caused by chemotherapy. But the good news, again, there are things we can do to help. Problem-solving exercises, word memory exercises. So we have a specialist that does that. But how do we identify the patients and get those patients to our specialist? That's what we've set up infrastructure to do. So we do the distress assessment. If a patient reports memory issues, cognitive issues, problem solving, we will set a trigger threshold that will refer them to that service. We've done that for cardio-oncology. Some of our patients have a high risk for having heart problems based on the types of cancer treatments they will have. We identify those proactively, we set the trigger, and we refer them to the cardio-oncologist. Our cardio-oncologists, we have 2 now, who have ramped up to almost full-time, 2 days a week in our clinic. Because there's that much need. And we've been able to develop the infrastructure to facilitate that. We have a smoking cessation program that we've helped to link patients to. We have an ostomy education program that's kicking off this year. And we're starting audiology screening because we know that hearing can be damaged with some of our platinum-based therapy drugs, our ototoxic drugs.
Oh, wow.
So we're triggering those referrals based on who's going to get the drug, which puts them at risk, and we say, great, let's get you to the audiologist now. So the goal is find these individuals who start to develop the needs now as they're going through treatment, mitigate the downstream, but they also now have someone walking next to them. So we may be able to assess, screen, rescreen, find the problem, manage the problem. And guess what? In 6 months, they say, oh, I'm starting to have this balance issue or this memory issue. I have someone that I can go back to. They're not questioning, who do I go to? Who's my person? So we're trying to create, as I said, this system of care that follows them during treatment. And guess what that leads to? It leads to a better handoff and segue out into the community.
Sure.
Because they've got a contact person, they're knowledgeable, knowledge is power. Patients feel empowered when we say, yes, this is a problem, this is valid that you feel this way, this is validating their concern about the issue. It isn't just a hand wave of, oh, it's going to go away after a couple of months or years after you're done with treatment, because it may not.
And it sounds like there are so many different services out there.
yes.
You really do need a navigator.
Navigator, that's a great word, and that's a fantastic concept. So navigation is a very prominent concept in cancer care delivery. In fact, navigators are core in many cancer institutes. We are working to develop navigation systems and pathways here at WVU Cancer Institute. And there are different ways to structure that, but that's essentially what we want to do, is navigate the patient to the right specialist at the right time. So our cognitive therapist, our cardio-oncologists, they're all out there, right? We have neurological specialists. We have physical therapists who are specialists in oncology. What our system and infrastructure through this program has done is it's enabled us to get the patients to the provider of the specialty care proactively. So
Sure.
before they become disabled, before they can't get out of the house and do their daily shopping. Before, we have financial counselors. So we get to patients before they have their electricity turned off, before they lose their job. We're trying to be more proactive in prospectively doing a surveillance program with these patients.
I bet a question you would get a lot from patients, will their insurance cover many of these services and programs?
Yeah, the answer is it, of course, is dependent on the insurance program,
Sure.
but for the most part, all of these are covered, a part of an essential benefits package, for example, through Medicare. Rehabilitation, those services are covered through Medicare. A lot of these services we offer within the Cancer Institute. Our social workers are there. Our dietitians, we have 2, they are there. Our chaplain is there.
Sure.
They are consulting, working with these individuals and helping to facilitate their supportive care during treatment. And they're not a separate billable entity. Now, as they move out into the communities, again, it will vary as to what is covered. For the most part, these are covered by insurance, these services. They're all medically based. Patients may experience copays to varying degrees. We should anticipate that as well. The bigger issue, I think, isn't is there a service, is it paid for? In many instances, it's paid for. There might be a service, but they don't have specialty knowledge in oncology. Mm-hmm. And that's what we run into when we get out into the communities. Our primary care providers, they're everywhere. We have, rehabilitation providers everywhere around the state, social workers, community health workers. But what do they know about managing the long-term needs of cancer survivors? Sometimes that's the gap.
Yeah.
Payment for the services is there, but they walk in the door and the physical therapist says, I don't know much about working with someone who's had cancer. And so maybe they're not getting the best care in the community. So
Sure.
We are identifying those gaps and trying to increase workforce capacity and knowledge to help to better manage these folks comprehensively.
Well, we have a question from one of our viewers who is asking, does the survivorship program assist family members of patients?
Oh, that's a great question.
Mm-hmm.
One of the most important things that we have begun to focus on is caregiver and family members. We know adults going through cancer treatments, if they have children, many times their children struggle in school. They will struggle with peer relationships. Spouses struggle when their loved one, their husband or wife is going through treatment. We focus on comprehensively managing the needs of the patient, and that means the family members. So it is critical for us to think about how do we engage, is there family counseling that's needed? Is there relationship counseling perhaps that's needed if individuals have sexual needs or intimacy concerns, body image, and those types of things. So we do aim to address caregiver needs and understand the caregiver support structure that needs to be put in place. We will be conducting a needs assessment and barriers assessment this year in our Cancer Institute. And I'm happy to say we've changed the structure of how we're going to do that. We're going to have a survey for our patients so we understand the issues that they're facing. But we're going to have a separate survey this year for caregivers because their needs, it's a great idea. Their needs are different. They are so important to the survival and the durability that patient experiences getting through treatment. And we just say, the wife or the husband, they take work off. They have to be there and drive the individual back and forth. Many times they're sitting there in the chemo suite with them for 4 or 5 hours because they must be there to drive them home.
Yeah.
So we have to really look closely at those unique and individual needs of the caregiver, of the family members, and think about how we address holistically the whole person.
Yeah, a lot of needs for everybody,
Yes, a lot of work to do. So there's opportunity, a lot of opportunity.
Yeah. So before we go, I have to ask you, what's the most important thing you want our viewers to know and remember about the WVU Cancer Institute survivorship program?
Oh, you threw that trick question in there at the end.
That's not a trick.
It's hard to identify just one most important thing. I think the thing to keep in mind is if you're listening to this and you're a patient or a caregiver of one of our patients, please speak up. Please ask the questions of your physician to understand, help them understand if you're having fear, anxiety, if you're having pain, if you're having issues at home, financial issues, or challenges with social relationships, driving. Talk to your doctor. Sometimes patients think, well, this isn't about my disease, my cancer treatment. I'll just figure this out, right? We'll just figure this out. We've had patients say things like, I didn't have anybody to drive me, but my church lined up somebody to drive me to every one of my appointments. And I didn't feel like I could talk to my doctor about that because that really didn't have to do with my cancer. That was my problem to deal with. Oh. And I would say what we are trying to do is to create a system that helps you handle all of that. So speak up. Your nurse, your physician, your social worker, tell them the things that you need, that you're struggling with, regardless of what it might be. Because when you're going through cancer treatment, it is all related. It's all related to the treatment. Sure. It's very stressful. So how can we help you is what I would be thinking about. Tell us. Help us understand what we can do. Absolutely. And don't feel like you're troubling your doctor or your nurse by asking those questions. Yeah. They will be able to use our infrastructure and system to help to direct you to the right place at the right time.
Wow, great. Such good information. Thank you so much for sharing all this today. I think we've helped a lot of people today. And, thank you for telling us all about it.
Yeah, thank you. Mm-hmm. I'm excited to see the clinical line go forward, but also our research. We're developing an extensive line of research to study these programs and understand what works best where. So we're grateful for an opportunity like this to promote the program, and thank you for having me.
Okay, great. So that brings us to the end of this edition of Tuesday Talks. If you're looking for more information on cancer survivorship, visit wvumedicine.org/cancer. And join us on Tuesday Talks on April 18th, when we'll talk about pediatric hip preservation with pediatric orthopedic surgeon Dr. Andrew Parsons of WVU Medicine Children's. I'm Mary Ravazio Menard, and on behalf of Dr. Stout and everyone at WVU Medicine, thanks for joining us and have a great day.